We will get started. My pleasure to introduce to you Dr. Dorin Deitch, and we'll take it away.
Well, thanks for that, Julia. Once again, just wanted to introduce myself. I've done this lecture, I think, once before, and I'm happy to see that we have a lot of people who are stopping by to see it either again or for the first time, and maybe getting a little bit more information on the topic. But I wanted to come in and talk to you guys today about the importance of having an interdisciplinary and collaborative care team with the management of Parkinson's disease. So I'm Dorin Deitch. I am resident trained in physical medicine and rehab. And despite the fact that I'm a rehab doctor, I'm also neurology trained and fellowship trained in Parkinson's and movement disorders. I did my fellowship at Henry Ford, West Bloomfield with Dr. LeWitt, Dr. Balika, and many other physicians there. Dr. Patel, who since left and went to Chicago. So I'm sure you guys have experienced maybe a few of those physicians. Also, I did my residency training here in Michigan at Royal Oak Beaumont. So I'm local, I'm from this area, and I care deeply about this community. So, I'm trying to give the Parkinson's community a little bit of a full rounding out of care, and just another person to add to your collaborative care team to try to get the most out of your quality of life while living with Parkinson's disease. So feel free to tell anybody who is either in this chat who has Parkinson's, or that I'm happy to see anybody, and hopefully you guys can use what you learned today and implement it into your everyday lives. So just to start, there's many people who are involved with your treating your Parkinson's disease. So most people have, at a minimum, a general neurologist, and probably many of you have a movement disorder specialist or movement disorder neurologist who is at the forefront of your care. And a lot of times this person becomes your de facto primary care provider for you. And, any and all questions do seem to pertain to your Parkinson's disease, and, symptoms, even if they seem completely out of whack or irrelevant, somehow get related back to your Parkinson's disease. But, it's always important to have multiple different people working on this, because Parkinson's is a multi-system disease. It's not just dealing with one specific thing. And there are many people who are here and available to help you manage and get through this. So, a lot of times the first people that the neurologist leans on are physical therapists, occupational therapists, speech therapists, because it impacts all aspects of your life. I certainly wouldn't be amiss to mention the support groups that are important, like the Michigan Parkinson's Foundation and, local close support groups. It's still important to keep close contact with your primary care physician and geriatrician, especially with how Parkinson's interacts with your preventive care and your everyday care. Additionally, you may need a geriatric psychiatrist if you're dealing with. Oh, hold on.
I can find it.
Julia, are we able to meet everybody here?
I'm trying right now. We're just gonna mute. Want to mute everybody?
Yeah.
So if you guys are just logging on, try to mute your connections if possible. All good. Yeah, if possible.
Can you hear me?
I can hear you.
Okay, we're good.
Okay, great. So in addition to your primary care provider, you may want to have access to a geriatric psychiatrist or a psychiatrist in general, especially when you're dealing with, aspects of depression, anxiety that could be related to Parkinson's disease. Hallucination sometimes can be a symptom of Parkinson's disease as well. As the disease progresses, you may need a neurosurgeon for deep brain stimulation surgery, or a palliative care physician is always actually a good support system person for the general population of Parkinson's disease, because palliative care is going to talk to you about how to cope with chronic disease processes and how that may, apply to your everyday life and what you may need help with. You definitely cannot overlook a caregiver support, as the caregivers often bear a lot of the burden of Parkinson's disease. But finally, one thing that might be a little bit overlooked in terms of fitting into your Parkinson's care is the thing that I do, and that would be physical medicine rehab or physiatry. I don't know if anyone has interacted with a physiatrist before, but I'll go in further about explaining what exactly we do. So from a physiatry standpoint, what do we do? So a physical medicine and rehab doctor is trained in both musculoskeletal conditions. So we see people in the office for back pain or leg pain or, a sports related injury. Additionally, we see people for neurologic conditions. So stroke, brain injury, spinal cord injury, Parkinson's disease, all of these things fall under our purview. And really our goal is to try to be basically like your primary care provider for neuromusculoskeletal conditions and the interaction between the two. So we're very well trained in many different techniques. We're expertly trained in pain management, in rehabilitation techniques, in interventions, and we try to be experts in musculoskeletal and neurological anatomy. And we try to apply this anatomy to allow individuals to get the best quality of life they possibly can and to function their best. That's our main goal. So, we may not be the focus of diagnostics. An old trope from neurology is that they used to say that the neurologist would diagnose and adios. So, there's nothing they can do, but that's okay. Our goal as physiatrists is to look at the patient as an overall. How do we establish a good quality of life for the patient, and how do we get them to maximize that? So what are some certain things that we could address? Well, musculoskeletal pain, back pain, leg pain, stiffness. I do Botox for dystonia as a movement disorder trained rehab doctor. We do Botox for spasticity, for traumatic brain injuries and spinal cord injuries. We also help try to guide the therapist for rehab. So, physical therapists are unbelievable and super important aspects of our community and in terms of our care. But in general, if you get sent over to a physical therapist for back pain, you're really asking the therapist to do most of the diagnostics. So our goal is to help try to diagnose the patient as specifically as possible and help guide the physical therapist to execute a plan for rehab. Additionally, we help develop home exercise plans. We're trained in bowel and bladder management, so we address both of those, which can sometimes be affected in Parkinson's disease. We like to address equipment needs. So if you need canes, walkers, wheelchairs, ankle foot orthoses for foot drop, a myriad of other braces, orthotics, prosthetics, all these kinds of things all fall under our purview. And really everything is just there to, how do we increase your quality of life and how do we improve function to allow you to get the most out of your life? That's our main goal. Our goal is not necessarily diagnostics. Our goal is to, how do we make you feel better? So in contrast, a movement disorder specialist or neurologist might be, someone who's very familiar with Parkinson's disease and those associated conditions. They're very well trained in botulinum toxin injections for dystonia. They have an expertise in the medication of Parkinson's disease. They're well trained in cognitive changes and dementia. They have an understanding of both the motor and the non-motor symptoms of Parkinson's disease that may be affecting you. And additionally, a lot of them are in academic settings, so there should be knowledge about research, upcoming treatments, and be able to help guide you if there's any surgical treatment such as DBS that needs to be addressed. So how does a physical therapist fit into your care? Usually they're giving Parkinson's patients the tools to succeed and kind of be giving them a guideline on how to move. And, one of the things that was taught to me really early on was the only thing in Parkinson's disease from a treatment standpoint that actually modifies the disease and allows someone to live longer with Parkinson's disease is movement and exercise. And it's non-specific for that. So it can be anything, but as long as you are constantly trying to move, exercise, and continue to do the best you can from a movement standpoint, that can help increase your lifetime. So despite the fact that all these medications are great and may allow you to be less stiff or move easier or all those kinds of things, in isolation, the medications do not actually extend your life with Parkinson's. But if they allow you to move easier, so then you move more, that enhances your life and allows you to live longer with Parkinson's. So additionally, physical therapists may work on LSVT, which is Lee Silverman voice training. I'm sure many of you guys have seen big and power therapies, trying to work on bigger movements, working on extending your range of motion, working on trying to use multiple different systems, modalities, and interactions within the brain to form new connections. Gait and balance training is extremely important as you lose some of your balance centers in your brain with Parkinson's. Trying to work on physical techniques to combat freezing. Developing home exercise programs are incredibly important. And sometimes aquatherapy can be very helpful as well, because it takes some of the weight off of patients who are, might be having more ailments, who also are ailed with, osteoarthritis and joint related pains and stiffness. This may help them from a fluidity standpoint. In terms of speech therapy, there are many voice exercises. Usually your speech tends to get a lot quieter when you get diagnosed with Parkinson's. Sometimes your swallow can be affected with Parkinson's. So that's another important area where they can work on making sure that we're working on swallowing exercises. Additionally, Parkinson's, because it is a neurodegenerative disorder, it is going to be, it may affect your cognition long-term. So obviously getting continued cognitive therapy and understanding, especially if there are cognitive changes, how to combat those, how to continue to work on your cognitive functioning. These are all things that speech therapy can address. Also, managing secretions is something that would fall under their purview too, and that's extremely important as well, especially with sialorrhea and excess drooling. So that's something to look out for. From one of the modalities that's a little bit more underutilized that I think really would get, very important usage for Parkinson's patients is occupational therapy. So most of the day, and most of the frustrations from patients are that I'm not able to get in and out of the bathroom as easily as I used to. I'm not able to get in and out of bed like I used to. It's really difficult for me to shower like I used to. These are all things that the occupational therapist addresses. So although it's underutilized in the Parkinson's community, we should be going out of our way to utilize these resources for occupational therapy. Additionally, it focuses on a lot of the ADL management. So what are your activities of daily living? How are we getting around, brushing our teeth, eating, cooking, going to the bathroom, all those kinds of things. And then also, occupational therapists are experts in how equipment can help modify activities to make us more functional and give us a better quality of life. Additionally, they can do home visits. So this may be something to look at, especially if you have more advanced Parkinson's, or home safety may be an issue. So having home visits to help assess for home safety, equipment recommendations, all those kinds of things can be super important and really, really helpful, even though it's usually overlooked. Additionally, patients with Parkinson's disease can sometimes get tenting of their hands. So even a hand-specific occupational therapist can work on dexterity, hand pain, bracing, using different modalities for all of these things. We kind of talked about some of these earlier at the outset, but the neurosurgeon is important in case your dyskinesias are overly bad, or your tremor is overly bad, and deep brain stimulation may be required for you. So that's someone to have in your back pocket. your primary care physician looking at your preventative care, because it's important to not overlook those things, from your cardiac health, from your, preventing strokes, because still the number one cause of death in patients with Parkinson's are heart related diseases and chronic conditions. So, coronary artery disease, heart disease, heart attacks, these are all still the main reasons why someone would be most likely to die in Parkinson's. So having a good primary care physician or geriatrician is super important. We talked about psychiatrists, psychology, behavioral health. These are all super important people as, managing mood related disorders, and also coping with not just a chronic disease process, but sometimes chronic pain related processes. The gastroenterologist can be important, especially when some patients experience difficulty with their stomach function, with their delayed gastric emptying, or swallow with their esophagus. So that's an important person. The palliative care physician may be important, especially as you start to age through the disease process, and they can help be a good reach out for more resources to try to help you, using support groups, family, friends, spousal support, all caregivers. These are all hugely important members of your team, not to be overlooked also. So I wanted to keep it short and sweet to allow you guys to have, some questions on what I'm doing. And if you have any questions about physiatry in general, or even just Parkinson's in general, I am here for any and all of your questions.
Thank you. That was great. And I do want to remind people that they'll have to unmute themselves to ask a question. And if you're having any difficulty speaking, we have a chat box as well below at the bottom of the screen for any questions. There is a raise hand feature if you know how to use that as well. But feel free to jump in with any questions. And while you're thinking of those questions, I just wanted to be clear about one thing, and that is, so you do treat people with Parkinson's and Parkinsonisms. You do Botox injections for dystonia, spasticity. Do you do it for drooling?
I do. Yep. I do it for drooling, for sialorrhea. I'll do it for focal dystonia in the feet. I'll do it for striatal toe. I'll do it for hemifacial spasm, blepharospasm, any and all movement disorder related issues, including, sometimes orofacial dystonia. So, not to mention like other stuff from a rehab standpoint that we take care of, like migraine headaches, spasticity from, brain injury, spinal cord injury, MS, stroke, all those kinds of things as well. But yes, so I take care of Parkinson's patients from both, if they get referred over to me in collaboration with a lot of the neurologists around. I love having a neurologist as part of my care, because really I want to work with you from a musculoskeletal pain standpoint. How are you moving? How are your therapies going? What kind of exercise plan can we help develop? And, my preference is to not have to necessarily manage some of the, cognitive side effects, hallucinations. That's under the purview of neurology and psychiatry. And, I absolutely have the skills to manage all those things. But, it's good to have a neurologist on your team too, especially for a disease as big as Parkinson's disease that necessitates that. So, I'm happy to help out with all those things.
That's great, because that leads to another question. And I know we have a question in the chat box, and I don't want to dominate, but I could sit here all night and talk about it, as you know, Dorin. But many people oftentimes don't have access to a movement disorder specialist, and they may see a general neurologist. And we get that question quite often, is it okay? And I'm like, absolutely. In fact, there's nothing wrong with having multi-specialties on your team, exactly like what you said. So even having a general neurologist and for example, you, a physiatrist, a movement disorder specialist, might even be ideal for some people.
Yeah, absolutely, absolutely. And it's a good guess and check too, because I manage, I may manage people when they come over from a neurologist. I may manage them from scratch. There's plenty of people that I've diagnosed with Parkinson's and have, started the treatment. And not to mention if there's things that I see that I think would be better suited for a movement disorder specialist neurologist, I will send that over to them as well. So, I think I learned early on that it's not necessarily, what you know, it's kind of what you don't know, and
Right.
also knowing what you don't know. So, I'm certainly not afraid to ask for help on some of these things. And if you have a general neurologist who you feel really comfortable with, it's great because you can come to me and be seen for musculoskeletal issues, but I'm going to look at your Parkinson's medications also and make sure that you're on a good optimal treatment regimen.
Yeah, I think that's really a great model that I hope more people will take advantage of. I know we have a question, but just one more thing I was going to, just for clarity, you do DBS programming, correct?
Absolutely. Yep. I do DBS programming. Uh, what the good thing so far has been most of the people that I've seen have either already come to me on DBS, so I haven't had to refer them out because it's relatively early in my practice. So usually they're either coming from an established neurologist or I diagnose them and they're very early in their care. So, but I have a good relationship with all the neurosurgeons in the area with Dr. Schwab, Dr. Ayer. So
Yes.
it's a good option for many patients, and especially in the right patients. So, selecting the right things. I program for DBS, so if that's an option that you're interested in, then I'm happy to help with that also.
Great. Well, Roberta had a question. She said, you referred to bracing when discussing OT. What is bracing?
Sure. So, bracing may be, it might be most easily thought of and most commonly thought of, like, let's say you have carpal tunnel syndrome. A good way to help calm down a carpal tunnel syndrome is by using a brace that just goes over your arm. So it's just a piece of equipment that would help, in carpal tunnel syndrome, it would help limit you going into too much of wrist bending or extending so that you're not making your pain worse. So, some issues that, like, just because you have Parkinson's doesn't mean that you're immune from other musculoskeletal ailments, doesn't mean you're immune from arthritis or carpal tunnel or other issues that may just be overlooked just because you have Parkinson's, and really everyone wants to focus on your Parkinson's. So someone who can take both into context, I think, is important. So some people have foot drop, or sometimes if you have difficulty walking, you may need a knee brace. So some of these things are easily considered for us while we're evaluating the whole patient.
Like orthotics? Maybe?
Yep, absolutely. So, orthotics in the feet, especially if you have some aspect of toe curling dystonia, if you have, stiffness in your legs, sometimes it just takes as much as a knee brace, especially if you have knee arthritis, to help stabilize you and stabilize your gait a little bit more. So, we're looking at all the musculoskeletal issues, but also the neurologic issues too, and how they fit together.
Great. Well, thank you. We have another question from Vicky. Depression is an issue. Any meds that work well with carbidopa levodopa?
There are a bunch of good meds. So, first of all, I'd say when depression is an issue, what works with any medication is seeing a licensed psychologist and someone who manages chronic conditions, neurologic conditions, as well as mood disorders, because really, starting any type of depression management, I think personally starts with seeing a psychologist or a licensed therapist, as so that they can intervene on that. From a medication standpoint, the nice thing about carbidopa levodopa is essentially it's an amino acid. So, it shouldn't really have too many interactions with a lot of the other medications. So, obviously I would check your individual medications one by one with if it interacts with carbidopa, levodopa. But for the most part, there are very few medications that I restrict from taking it with carbidopa, levodopa as your Parkinson's medication for that reason. It's, it's naturally occurring in the body. But, carbidopa, levodopa exacerbates a lot of the, adverse effects and side effects. So if other medications that may make you, lightheaded or, drop your blood pressure, those probably aren't the best options for you, especially if you're already prone to that. So, taking everything in context is always important.
And I'm hoping that the stigma goes away a little bit about it. I'm hoping in 2023 we're getting there, but depression and anxiety go hand in hand with Parkinson's disease, and there is treatment. It is manageable. So thanks for that question, Vicki. I think it's an important topic. Sue said, you mentioned palliative, gastrointestinal, etc. doctors. Whenever we visit these people, they don't seem up to speed about Parkinson's. Are there the type of doctors who are up to date on Parkinson's connections to these problems?
So some of them are fewer and further between, especially because, there's not a palliative Parkinson's specialist or certification or anything like that, but sometimes what I feel like can help optimize your care with other specialists is having a good movement disorder physician who can help outline your care, help outline what your personal issues are, and also communicate it to your specialist that you're going to. It's just like going to your physical therapist and getting a script for back pain. Well, they're going to try to figure out what in the world is going on with your back pain. But if you tell them, well, they have, lumbar arthritis with facet pain at L5S1, and, we tried this, and this, and we want to try to do this as well, then they have a lot more of a narrow aspect of looking at your care. So, I consider that the same with palliative and GI doctors, that if you establish a good relationship with a movement disorder specialist, then their outlining of what you need can help guide their care a lot more closely. Like if you go see a GI doctor and you just show up there to be seen, they may say, well, do you have abdominal pain? And if that's not your, and if you need to see them because you have, delayed gastric motility because of your Parkinson's disease and your autonomic issues, then they should know that at the outset. So, I think advocating for yourself from that standpoint, I think is really important.
That's a great point. And, we talk often about having a team and a multidisciplinary team. But I think the reality is that there are not that many centers that really kind of have a one-stop shopping list. There are a few, and some are absolutely recognized through centers of excellence. But the majority of people don't have access to these multidisciplinary clinics, I think. And so I think being the advocate, having good communication with your team, it's really, you're the driver in this seat, I believe. So that's my 2 cents.
I completely agree. Julia, did you get this question from Cynthia, or was that sent direct to me?
That was sent direct to you.
Okay. So I think this is general enough to, talk about it with everybody, but she said, she told her movement disorder specialist that she has frozen shoulder pain, or that she has shoulder pain, and that the movement disorder specialist thought that she may have frozen shoulder. She said that the movement disorder specialist said to contact her PCP to get a referral for a physical therapist. Would it be helpful to see a physiatrist first? Absolutely. This is exactly in the purview of, what we do. Our goal is to help, this also comes down to utilizing resources and time efficiently and effectively and all these kinds of things. Like, your time is precious. I know when you have Parkinson's, it's difficult to get around. It's difficult to get to PT. The absolute last thing you want is to get a script for a physical therapist, go to physical therapy, and for them to start working on your frozen shoulder that you may not even have, because at the end of the day, if you're a neurologically trained movement disorder specialist, they may be right. You may have frozen shoulder, but it's not necessarily their specialty to address things that are more musculoskeletal focused. So, getting the right diagnosis, seeing what the other options are, especially because we could do, intra-articular injections. So, steroid shots in the joint, it may be a neurological issue. So we may want to do like an EMG or do further workup, get x-rays. So just to say, this is for sure frozen shoulder, and then to go to a PT may not be the most effective utilization of your resources, especially when so many of these insurances are limiting how many times you can see the therapist also, especially when you have Parkinson's too. So you definitely want to try to maximize those things. So if you're able to get a referral from a PCP or even from your movement disorder specialist to go see a physiatrist, I think that's a great thing to start out with, right away.
And I think that this kind of brings up an issue that it's really kind of a balancing act, because you can't really blame everything on Parkinson's and then potentially miss something. And a lot of people, I will field many phone calls where people will say, okay, I want to see a Parkinson's specialist for mental health counseling. Well, there are no such mental health providers that just specialize in Parkinson's. I think you mentioned it earlier, Dr. Deitch, about having a psychologist or a neuropsychologist or a therapist who deals with chronic or long-term illnesses. That really, I think, is where you're going to find benefit for the mental health issues. But this is just an example of many of the specialties as well, I think, because you aren't going to find a Parkinson's palliative doctor. You're going to find a palliative doctor who has handled Parkinson's, hopefully. And if they are not educated, I want to tell you, as part of my job, I'm supposed to be going out educating people. So if there are groups or doctors that don't know what they're doing or talking about, or they don't have the information in their pocket about Parkinson's or Michigan Parkinson's Foundation and the resources, please feel free to contact us, contact me, and we will reach out. No question.
Definitely. That's great. And then also kind of pertaining to Cynthia's question also, like I distinctly remember when I was in fellowship, and because I, was fully trained as a rehab doctor prior to doing my fellowship, I remember we were seeing a patient who had, very severe Parkinson's disease, was young onset, who was having horrible dyskinesias. And the attending that I was working with was having a really hard time differentiating what the reason was. It seemed to come about so abruptly, all these kinds of things. And then, so she asked me to come into the room to evaluate him from a, musculoskeletal standpoint also. And the patient said, well, yeah, actually over the last couple of days, I've had pain shooting down my leg, and I went to the ER and they told me to take steroids and I didn't take them. And, I've been having, horrible, numbness, tingling, and burning pain. And I'm like, well, yeah, you have a pinched nerve in your back. No wonder your dyskinesias are horrible.
Wow.
So take the steroids, because that's going to make you a whole lot better. So, sometimes everybody needs a little bit of help. So looking at some of those things is really important.
And fresh eyes.
Yeah, absolutely. Because sometimes you can be too deep in the weeds on a person and have things figured out one way, but sometimes just having a fresh perspective makes a big difference as well.
Right. Okay, we got another question here. I thought podiatrists treat feet issues. Confused as to why a person with frozen shoulder would go to them. Did I hear incorrectly?
Yes, sorry. So it's physiatry. I know we get confused with podiatrists, we get confused with psychiatrists. It's very common, but physiatry or physical medicine rehab, we're treating all of, basically all the parts of the body. So everything from your head to your toes, from a musculoskeletal and neurologic perspective, we're treating all of that. So one more thing I also just wanted to add for people, because I know that sometimes this doesn't necessarily get addressed all the time, but I see people in a lot of different settings. So I see people in the office, but I also round in the hospital, and I also round in nursing homes as well. So, if you are specifically looking for resources or need help from let's say you're a patient or your family member was recently in the hospital and needs further rehab before going home safely, you guys can always reach out to me and see if facilities that I'm going to are reasonable for you to also get further long-term care in from a subacute rehab perspective as opposed to in the office or in the hospital.
That's good to know. That's good to know. I think nursing homes are an area that we are concentrating on as well, trying to get, not from teaching them how to take, a physician's approach, but their support staff and getting them familiar with Parkinson's disease. It's something desperately needed. And the Michigan Parkinson's Foundation received a grant a couple of years ago, and there is a 7-video series on our YouTube channel that is all about caregiving and education, and most notably directed to facilities. So we have been working with facilities to get them in as part of their education modules, that they have to learn about Parkinson's disease in order for them to even receive a referral from the Michigan Parkinson's Foundation. And those videos are available to anybody on our YouTube channel in case you want. Patty has a question. Do you know anything about peripheral neuropathy in the toes?
Yeah, I may reach out to you to help with
Did I lose you? Freezing?
You're cutting in and out, but I think you were saying something at the end about peripheral neuropathy, I think.
Oh yeah, the question was, do you know anything about peripheral neuropathy in the toes?
I know plenty about peripheral neuropathy in the feet. We treat it all the time. It's a really difficult thing to treat, but happy to see you and come up with an individual treatment plan if that's part of your overall care needs.
I have another question. Can you tell me, many people have said that they've been referred for Botox for their tremor in their hand. I wasn't sure. I didn't think that Botox was really something that works well with tremor in the hand. Can you talk about that?
Yep, I would love for people to get referred over to me for Botox for tremor, because then I can put them on the right treatment regimen. Because I don't think, the issue with the tremor is that it's not really one specific muscle or one specific area. And the last thing you want to do is take muscles that are functional and make them non-functional, which, Botox is going to weaken the muscles. So I usually don't recommend that. I think there are people on the periphery who, do try it, but, I would think that it would be very difficult to get the exact dose, quality, and treatment of the tremor without actually making the muscle too weak to be functional, and people who, could have better treatment overall. So, oral medications do a pretty good job. And if not, then, I would certainly consider deep brain stimulation before botulinum toxin injections for that.
Yeah, great. I'm glad you answered that one. Do we have any other questions that anybody would like to ask? Look, you did such a good job. Nobody has questions.
Yep, it's like when everyone gets scared in school to ask questions. But you guys can always call our office or even shoot an email. All of our information's on our website. So our website it's pretty straightforward. It's rpmpmr.com. So if you need to get a hold of us or reach out or have a question to ask, we're happy to respond and get back to you. I'm on nearly every insurance, including even the difficult HAP ones that have to go through Henry Ford and the like. So whatever, if you hear this talk and need further assistance, we're happy to help you and get you in as soon as we can. So
do you do virtual visits, or I would assume that I know that can be a little difficult with movement, but even consultations or anything like that, do you do
So,
virtual?
we try to not do initial consultations virtually because it's so essential to see the person for movement disorders. You
Yeah,
know, if there's a long standing treatment plan already in place, and you know you just got out of the hospital or something like that, then we can try to accommodate with virtual visits. But you know, for the most part, the government's kind of taken away our reimbursement and our ability to do virtual visits now that COVID has kind of calmed down a little bit.
right. Cynthia has a
So we're a little bit
question.
limited.
Cynthia?
Yes. Do a lot of your patients, do you find that they come to you after they've been to a number of doctors and maybe they've been misdiagnosed, or do they typically see you first and then?
It's definitely a mixture. So I've seen, you know, there's been a handful of patients who have come to me directly, and you know, one of my partners has seen them and said, hey, they have a tremor, go see my partner who's an expert in tremor and see what's going on. And then I diagnose them with Parkinson's, or you know, or they get referred over from other people, or you know, hey, I have a family member that has Parkinson's, and my dad had Parkinson's before he passed, and I just want to make sure that I don't have it. Or, you know, I see a lot of people for a lot of different reasons. Or sometimes even I'll discover it in seeing someone for, you know, back pain or hip pain. Actually, one patient that I saw who I diagnosed initially with it had tightness in their shoulder, and went and got shoulder surgery, got a total reverse shoulder replacement, and then came back and was like, well, my shoulder's still really sore after the surgery, but was starting to develop a little bit of a resting tremor. And that was really because they had Parkinson's. I've seen a lot of people who have gotten surgeries because of stiffness of joints in different areas that was never really addressed, which, you know, if you don't have a neurologist, why would it? And it gets missed until later on. So yeah, there's plenty of people who have seen many different doctors, or I'm the first person that they're seeing. So, you know, happy to try to fit in wherever I need to.
Great question, Cynthia. Any other questions? Well, as a reminder to everyone that, you know, the Michigan Parkinson's Foundation has free exercise at 10 a.m. on Zoom. And, you know, you got to keep moving, right? If you sit down in the lazy boy and stay there, you're going to stay there and not move. So you got to move, and you do yourself a favor and you do your caregivers a favor as well. If you are unable to make our free exercises at 10 a.m., you can see the exercises. We record them and they're on our YouTube channel as well. So you can do it like, you know, when maybe your meds kick in and you're feeling at your best to try it. Don't try an exercise when you're wearing off of your medication. I think that would be an uphill battle. But yeah, those are available. Cynthia, raise your hand again. She has another question. Go ahead, Cynthia.
I have a question. Can I make a sort of an announcement about the PD Expo this Saturday, where you can try out all different forms of exercise at, where is it, Rochester University? I mean, not Rochester,
Yeah,
Oakland University in Rochester.
It's actually on Friday.
I'm sorry, that's
Yeah.
right, Friday.
It's Friday. It is from Allie Werner, who is at Oakland University for Take Root is what it's called. And it is an expo. Yes, thank you for bringing it up. I know we are going to be there as well. Of course, if you ask me what time it is or anything, I don't have that right in front of me. But
It's 9:30 till 2.
9
9:30, you go to the takerootdance.com, and their website will give you all the details, and you can register there. But you'll be able to try Tai Chi, yoga, what's the polling? I forget that.
Oh yeah,
Urban
the walking
polling.
stick, urban polling.
No,
Yeah.
there's other things you could try. Rock steady, and there'll be classes, and you can you don't have to. Yeah, you don't have to sit through the whole class. You can just kind of go around and try out different things.
Yeah, that is
And
so
the
great.
campus will be very well marked.
Yeah, that's such a good thing. Great opportunity, so you can try it. I think yoga's there too, and yeah, I think they've got everything under the sun. I'm not sure if they have pickleball.
And Pilates.
Oh, Pilates.
No, they have Pilates.
Great.
Yeah, I have one more question just related to exercise. In our support group, there's a couple of people who still work, so they can't, most of the rock steady and other things are held during the day. Are you familiar with any organization that offers classes in the evening or Saturdays for people with Parkinson's?
I'm not acutely familiar with any programs that are specifically for nighttime or weekend, but I know that there's a lot of either the Michigan Parkinson's Foundation or the Parkinson's Foundation website or the Michael J. Fox Foundation. I think they all have recorded exercises, big and power therapies, and home exercise plans that are, able to be accessed online. So I think there's a lot of resources where you can access them online.
Well, and this is a perfect segment for me to announce. This is breaking news. I don't know if anyone has been notified about this yet, but we are very lucky at the Michigan Parkinson's Foundation to have hired Angie Ludwa, who is a physical therapist. She is so experienced. She's fantastic. She is one of our instructors on our platform. And one of our goals is to expand more exercise opportunities for our constituents throughout the state. So that's breaking news. It's coming. We're really lucky to have Angie. I've worked, previous to working at the MPF at Henry Ford with Dr. Lewitt for 24 years. And Angie has been in it, I think, just as long. And so the fact that she's here to make a contribution in that forum is going to be excellent. So more to come.
That's awesome.
Yeah, it's great. Any other, I think we probably can do another question if anybody has any. No? Do you have anything else that you want to add, Dr. Deitch? I can't thank you enough. This was a great presentation. I'm sorry if I were freezing or had any IT issues. To me, it was great, so I can't thank you enough.
Absolutely. I'm happy to help, and I love, this community is such a great community. So, I just want to help out Parkinson's patients, wherever they need it. And I know there's, people are scattered all over and have their own neurologists and movement disorder people. And, I just want to be an extra resource for people for whatever they may need. And sometimes, some of our front desk says, well, do you see this type of patient? Well, do I see them? I'll see anybody, because I know at a minimum I'm going to get them to where they need to be so that they can start to get better. So, even if it's me facilitating you getting to someone else, I'm happy to help as a resource for the Parkinson's community. So whatever you guys need, and hopefully I'll be able to see some of you guys around.
That's great. All right, well, I think that will conclude our program. And like I said, for anybody who is interested, please mark your calendars for Tuesday, July 25th. Oh, yeah, okay, July 25th at 7 o'clock on this channel again, our our education Zoom. That will be Kristen Rossi reviewing everything that she learned, and Angie Ludwa will be on that call as well to talk about what they learned at the World's Parkinson's Congress. Tuesday, August 1st, the Michael J. Fox Public Policy Officer, Mason Ziegler, is going to talk about the National Plan to End Parkinson's Act and how you can help, which is important. And then Monday, September 11th, for any veterans out there, we're going to have someone from the Veterans Administration talking about disability and Parkinson's disease and Parkinson's isms. So that, I think, We have all seen reports about environmental causes that are kind of growing with Parkinson's disease, and the VA certainly has recognized this and are stepping up. So please share that information, as well as many more programs like this. All right, well, with that, I hope everybody has a great evening. Thank you again, and we'll see you soon.
All right, thanks, guys.
Bye.